Good morning, everyone, and welcome to our podcast, PT Pillow Talk, where we tuck nerves in,
cover them with blankets of anatomy,
and try to make even the trickiest pathologies feel bedtime friendly. I'm Kenzie.
I'm Trisha.
And I'm Sage. Yes, like the herb. We are PT students at Russell Sage College, which makes it extra confusing because people keep asking me if I named myself after the school. Spoiler, I did not.
Thank you for the clarification. Really do appreciate it. Thank you.
So tonight we're here to help you drift off into the world of ulnar nerve syndrome at the wrist.
This is a pathology that sometimes keeps your pinky and your ring finger tossing and turning, making your hand feel a little restless at night.
So pull up your metaphorical pillow, snuggle in, and let's tuck the ulnar nerve into its proper place as we talk through its anatomy, symptoms, and what happens when it gets sleepless. So Trisha, since I didn't actually get to read the whole case, can you tell me a little bit more about it?
I think she's kidding.
I hope she's kidding.
I'm kidding.
Okay. So this case is by a couple MDs. We have Pierce, Steenberg, and Wolf. They published this study on June 9th of 2009, and this is basically targeting and looking at ulnar neuropathy specifically at the wrist. So this study follows a 29-year-old female who is right-handed and has been experiencing numbness and tingling for 2 weeks in her right hand. She notices that these symptoms are aggravated by typing and putting ice on her hand. She says that she has no history of trauma or injury to the head or the right upper extremity, but then later reveals that she did have a right shoulder labral tear. She had this treated by a arthroscopic labral reinsertion in February of 2007, but she also did confess prior to the surgery she did experience similar symptoms to what she's feeling now, and she just assumed that it was her shoulder. And you know what they say about assuming?
It's not good.
Yeah. That's
we'll
leave it at that. That's what they say. Yeah. So the examiners then went in with a full test. They cleared her C-spine to make sure there was no risks there. They did a Wright's test that was negative. They also did an Adson's test, which was negative, thank goodness. They did a Tinel cell over the median nerve, which was negative, and a Phelan's test, which was also negative. They did note that there was mild weakness of the abductor digiti minimi while they were doing the Frohman's test and the Wartenberg test, but those were presumed to be negative. Although all these tests were negative, they did do a Tinel sign at the ulnar nerve at the elbow, and they did say that was positive as the patient was experiencing radiation of pain to her fingertips. From further examination too, they also noted that the medial half of her palmar aspect of the hand with the 4th and the 5th digits did show decreased sensation to light touch using the Semmes-Weinstein monofilament test. The researchers from gathering that information then decided to put her in an elbow extension night splint that was prescribed with a nerve conduction study that was performed for 4 weeks. Do you know what a nerve conduction study is?
I do not.
I do.
Oh, okay. Yeah,
So,
what is it?
So a nerve conduction study, basically there's two types. The kind of overall arching term is an electrodiagnosis test, or it could be diagnostic. And it's just an electrical test that's looking at nerve or muscle function. The two types are EMG, which is electromyography, or NCS, which is a nerve conduction study. And these can be used in conjunction with location to determine some ulnar nerve lesions.
Wow, the more you know, the better.
The better your knowledge.
I feel like I'm learning so much already. All right, let's keep going. So, finishing off this case, both median nerves and the left ulnar nerve were normal during this conduction study. The right segmental motor branch of the ulnar nerve showed a little bit of reduced power. The right ulnar sensory test was done proximal to the wrist, which it did reveal that there was diminished sensation compared to the distal palm. But everything else presented normal. The electromyographic needle evaluation was at the right FDI. It showed a decreased recruitment pattern. Does anyone want to explain what electromyographic is?
It's kind of just another nerve conduction study, but it's more looking at the muscle. So this one looked at the first dorsal interossei muscle, and it's just going, a small needle is placed into there, and it sees just the action and the function of it to see if it's recruiting correctly and working with the other muscles correctly.
So from this, the right ADM showed abnormal irregular activity with the discrete recruitment pattern, which was decreased, it showed. From the electrodiagnostic evidence, it did conclude that there was compression of the right ulnar nerve at the wrist, at Guyon's canal. Do we believe this?
I can't believe it.
I can't believe it either.
I believe it.
Oh, you do believe it?
Well, these tests, they diagnose them, and that's like the best thing to
Sure.
work with it. So I believe it.
It's very specific that it was able to detect that it's at the wrist. And I think that's very interesting and very important for us as future physical therapists to just not overarch a diagnosis, ulnar neuropathy, but where? Where is it? Where can we treat it, right? Just to further confirm this diagnosis, an MRI was taken to look at the nerve closer, and it did also reveal a cyst that was 1.2 centimeters by 4 millimeters, which was up against the nerve at the pisiform bone. From this, what do you think happened next? What do? You have to get surgery. That's what the girl had to do. She did get surgery at the Guyon's canal to remove the ganglion cyst. And after the surgery, the patient did report mild decrease in sensation and slight dysesthesia in the ulnar nerve distribution of the hand, which is better than what she did report initially, which was the numbness and tingling, just a little bit decreased sensation. That was a lot of words. Sage, can you break down what I just said and maybe create a mental image of where we are in the body and what's actually happening in this pathology?
Yes, I can. Ulnar neuropathy at the wrist can be challenging to diagnose, which we said because its symptoms, such as paresthesia and mild weakness, are often vague and they can resemble other neurological conditions, so it's kind of hard to tell what's what.
I think everything's so vague, so that's why it's important to differential diagnosis, because things can present similarly, but to be treated can be vastly different.
Yes.
Yeah.
So, like I said, they could be vague and they could resemble other neurological conditions. And these include lower trunk brachioplexopathy or C8T1 radiculopathy.
Yikes.
Yeah. No, not at all. This overlap, it makes it difficult to differentiate between disorders, which is why understanding the ulnar nerve's anatomical course and its sensory and motor distributions is essential. Electrodiagnostic testing, like Kenzie said earlier, plays a vital role in confirming the presentation and location of the ulnar nerve lesion at the wrist, and in distinguishing them from other similar pathologies, like maybe such at the elbow.
So it just helps differential diagnosis where it is.
Yes, it targets down where exactly it can be.
Because the whole arm can be numb, but where is it starting from?
You gotta find where it's coming from. So anatomically, the ulnar nerve originates from C8T1 nerve roots and branches from the medial cord of the brachial plexus. It travels through the axilla, down the arm, past the elbow, and through the forearm before reaching the wrist. And it gives off the dorsal cutaneous branch to supply the dorsal hand of the palmar cutaneous branch, and supplies the proximal palm of both, which bypass Guyon's canal. So there's a lot where things could go wrong, and you don't know exactly where it is. The nerve enters Guyon's canal at a small triangle tunnel at the wrist. Yes. It's bordered medially by the pisiform bone.
What do you mean by that?
Triangle.
We'll go back to that later. Laterally by the hook of the hamate, and posteriorly by the transverse carpal ligament, which is just beyond this canal. The ulnar nerve divides into the nerve enters Guyon's canal, a small triangular tunnel at the wrist. It's bordered medially by the pisiform bone and laterally by the hook of the hamate, and posteriorly by the transverse carpal ligament. It's medial.
I think she's confused. I think you're confused. We already went over this.
We said this
close to my
5
body.
times. I don't get it. Medial. The side. Anatomical position. Sorry about that. Within or just beyond the canal, the ulnar nerve divides into superficial sensory branch and the deep motor branch. The superficial sensory branch provides sensation to the hypothenar eminence, the ulnar half, the 4th digit, and the entire 5th digit, medially.
Medial.
Medial, not lateral.
Medial.
The deep motor branch innervates key hand muscles, including the hypothenar muscles, dorsal interosseous muscles, and the 3rd and 4th lumbricals.
That's embarrassing.
That's embarrassing. You didn't see that. Third or fourth lumbar goes adductor pollicis, flexor pollicis brevis, and ends in the first dorsal interosseous muscle.
Very impressive.
It is impressive.
Very impressive.
And guess what? Compression of the ulnar nerve in Guyon's canal can result in sensory impairments, motor dysfunctions, and a combination of both. Your worst nightmare. And no, I'm not talking about MSK3. These lesions have traditionally been classified into 3 types, but more recent models describe 5 types, with electrodiagnostic testing being the most effective method for determining both location and classification, as Kenzie discussed earlier.
You know, Sage, you're so right. Because
I usually am. Go ahead.
I knew you were going to say that.
Go ahead.
So there used to be 3 types of lesions at the wrist for the ulnar nerve lesion / neuropathy, but now it's classified into 5 types, and these are based on location.
Did you say 5?
I did say 5.
Brought it.
So these 5 types, like I stated in the beginning, they're classified based on location and the electrodiagnosis test. Like we went over these could be EMG or NCS used together. First type that we have, which the girl in the case does have, this is a type that's located next to or within Guyon's canal. This can result in mixed motor neuropathy. Do we know what that means?
Mixed motor neuropathy.
Mixed neuropathy.
Motor.
Sensory and motor issues.
Good job. Gold star. So this does mean that is a combination of sensory and motor issues. This can occur deep motorally and superficial for sensory in the branches. Type 2 is involved only with superficial branches and is completely sensory neuropathy, so no motor branches are damaged, only the superficial sensory ones are. Type 3 is proximal, so meaning a little closer lesion to the deep motor branch prior to it having innervation to the hypothenar muscle. So this is before it innervates. This results in total motor neuropathy of this area, so complete motor dysfunction. Type 4 is complete motor. So this occurs after the innervation of the hypothenar muscles, so these ones are intact. Then we have type 5, the last type. This is a lesion occurring proximal to the distal deep motor branches of FDI and AP, like we talked about in the beginning. So this can occur over a tendon or a joint after a joint or tendon issue, like some trauma to it. There's 2 different types, proximal and distal. So proximal occurs at the piezotricutal or radial ulnar joints. These can be palpable and cause mixed deficits. But the distal ganglia occur at the distal row of the carpal bone, so further away. And these are usually not palpable and tend to have motor deficits. And they're kind of similar to type 4, where they spare the hypothenar muscles. So there was a study done that found that the most common cause of the ulnar nerve lesion, it tends to be idiopathic, so there's not really something known. But we do see most cases come in with the ganglion cyst issues. Other causes can include different traumas to the ulnar nerve, different artery diseases, fractures, and different systemic issues. So, ulnar neuropathy is a clinical diagnosis based on history and physical examination. This physical exam can include strength and sensory testing, as we stated before, and special tests that Trisha talked about, and also the electrical diagnosis. These can be atypical or nonspecific presentations, so they can kind of coincide with other diseases. That's why we really need to focus on the differential diagnosis of this to ensure that we are diagnosing ulnar nerve neuropathy at the wrist and not confusing it with some other nerve condition or at the elbow or brachial plexus injury. Stated before, the EMG and NCS are the most used testing to confirm the diagnosis, and these help to differentiate diagnose from other conditions because they tell exactly where it is and how it is affecting the ulnar nerve. As shown by patients in the case, she has ulnar nerve entrapment at the wrist due to the ganglion cyst at the proximal piezotricutal joint. She had some mixed symptoms with this, sensory and motor, and this is consistent with the type 1 lesion, and this is diagnosed once again by the electrical diagnoses.
So this case just kind of emphasizes why knowing your anatomy is really important in this profession. You can know that you may have tingling, and that does mean it's a nerve issue, but where is that nerve issue coming from? So this is why it's important that we focus on anatomy, and we pay attention in gross anatomy with Gaetano. We pay attention in biomechanics. We pay attention in pathology.
In MSK.
And MSK.
Can't forget about MSK.
It's important for our future profession and to really take care of these patients with all of the knowledge we can. That's it for this episode of PT Pillow Talk. Thank you guys for listening and watching and sticking around with us as we try to get through very difficult conversation. With that, we'll see you next time. Good night and sweet dreams.